and welcome to the Road to Genome podcast, which has now gone national, with this episode being brought to you jointly by the Genomic Medicine Service in both the North Eastern Yorkshire and the South East. I'm your host, Helen Bethel, Genetic Counsellor and Workforce Development and Education Lead. Today we're recording inside the busy Guy's Hospital, which sits in the heart of London. I'm delighted to be joined today by specialist midwives in monogenic diabetes, Bethany Evans and Nicola Young. Hi Beth, hi Nicola.
Morning.
Hi. Thanks so much for joining us this morning. You both have more than one role, so could you possibly start by telling us which of your roles it is that brings you to be podcast guests today?
So we are specialist midwives for monogenic diabetes, working for the GMS, and we've been in the role for 16 months,
something like that,
working across two of the regions. On a project to introduce testing for a form of monogenic diabetes within the gestational diabetes pathway. So pregnancy diabetes.
Great. So can you tell me a little bit about what monogenic diabetes is?
So monogenic diabetes is makes up about 5% of diabetes overall, and it's quite commonly misdiagnosed as other forms of diabetes. So it's otherwise called maturity onset diabetes of the young, or MODY. So generally patients are diagnosed under 25, and like we said, they're often diagnosed with a different form of diabetes, so either type 1 or type 2, but they have a genetic change in a single gene, and there's over 40 different genes that can cause monogenic diabetes, each with their own sort of clinical characteristics, and they can each have different treatment options as well.
So how does that relate then to midwives?
So midwives are providing care for women with gestational diabetes, and because they adjust the general population, same as everybody else, but they just happen to be pregnant, they've still got that same statistical chance.
Okay.
So about 1 in 1,000, which is, as Beth said, under 5% of all diabetes. Obviously, women come into pregnancy already having been diagnosed with diabetes, established diabetes, or they may be diagnosed with gestational diabetes during the pregnancy.
I see. So they're potentially presenting for the first time with diabetes, and it's being labelled as relevant to the pregnancy.
Yeah.
But actually, it's just the fact that they're under 20, potentially under 25, and it's the first time they're noticing. I see, that makes sense. So what does your role involve then as a specialist midwife in monogenic diabetes?
So when we first started the project, we did a lot of scoping to see what was already out there, and it became quite quickly apparent that there was a great lack of information for both professionals and public about the type of monogenic diabetes that we're particularly interested in. So our role is focusing on a subtype called glucokinase hyperglycemia. And generally in the general population, it's 1 in 1,000, but within the gestational diabetes cohort, it's about 1 in 100. So because we are testing people for diabetes for a huge variety of reasons, it's often the first time they've ever been tested. And outside of pregnancy, you actually don't need to diagnose glucokinase hyperglycemia because it doesn't need any other treatment unless people are pregnant or planning a pregnancy. But it can often be misdiagnosed as particularly type 2 or gestational diabetes. And that's where the problem then comes about, because we can potentially be over-treating these people.
Yeah, so once pregnancy's over, the treatment will continue, and actually
possibly
without treatment it can't actually resolve itself.
It's not so much that it resolves itself, because it causes a stable high blood sugar when people haven't eaten, so fasting hyperglycemia, because they are genetically predisposed. Do you think that's the right word? They don't need to worry about this type of hyperglycemia because it is mild. And outside of pregnancy, it doesn't need any treatment generally. People don't need retinal screening or foot checks. And because they can have a raised HbA1c, so a HbA1c we use outside of pregnancy to diagnose diabetes. But with people with glucokinase hyperglycemia, they can have a raised HbA1c, and it's in that small raise that they can then be misdiagnosed. And often the GPs will think that they need to treat it because they have a HbA1c of over 48. They think, oh, this is diabetes we need to then medicate and monitor, but actually it's completely unnecessary. So these patients don't need to be checking their blood sugars. They don't need to be going for
so
all
a
this
cascade
testing.
of intervention starts with the initial incorrect misdiagnosis of gestational diabetes. Once you've had gestational diabetes, you're much higher lifetime chance of developing type 2 diabetes. So generally, when women have had gestational diabetes, they then have yearly screening to check if they have gone on to develop type 2 diabetes. And of course, it's when that happens that people discover they've got a raised HbA1c and then they get labelled as type 2. So if we can avoid that by correctly diagnosing in pregnancy,
in the first instance,
you're preventing that later misdiagnosis.
And that sounds like that makes a huge difference to the patient in the long term, doesn't it, in terms of that, kind of over-treating. And
so with type 2 diabetes, you have obviously all the associated risk factors with macrovascular complications, etc. But that isn't the case with glucokinase hypoglycemia. So we kind of describe it as winning the lottery, really, because it's much better to receive a diagnosis of this than it is type 1 or type 2 or other forms.
So are you both working on this full time, or are you doing other roles alongside it?
We both have other roles apart from this. So we share this role between us, which is great because it's always better to have two heads rather than one, and everyone brings something different to the party. So that's always good. So apart from this, I have a role working in an NHS trust within the antenatal clinic.
Fantastic. And how about you, Beth?
So my background is as a diabetes specialist midwife. So in my clinical role, I'm looking after patients with type 1, type 2 and gestational diabetes. We will occasionally then get patients coming through with monogenic diabetes, whether they are diagnosed or undiagnosed is whether or not we can pick them up in pregnancy. But I think we've really, having done this role now for 16 months, you don't know what you don't know until you learn it. So when we have thought back about patients that we've had, we've then reflected and gone, oh, could that person have had another form of monogenic diabetes? And that's been really sort of thought-provoking, that actually, although the endocrinology team are very aware of monogenic diabetes, midwives and maternity services, we aren't. And actually, pregnancy is an ideal time to get the correct diagnosis for these patients because we are afforded extra testing. Pregnancy's almost like I always describe it to women as it's a well woman checkup, and we offer scans and blood tests and all these things that may give us more clues to could this person's diabetes have a genetic component to it. So it's a really good opportunity to re-examine existing diagnosis for these patients. And I always think back to a patient I had and I just think, oh, if I met her now, would I be...
That conversation would be different.
Absolutely. But obviously at the time when you don't know something, you don't know it. And now 16 months later, we're able to sort of rethink these things. So it's having those clues to get the correct diagnosis.
And how have you both found that kind of combination of clinical and project work sitting alongside each other?
I think we've juggled. We've both had a bit of a juggle. But I think, as Nicola said, we're very fortunate that within the job share we do, I would say, work very well together. And we both have different backgrounds and different strengths. But I think we couldn't have predicted how well working together would have
gone. Beth could have been a nightmare. I've been so lucky.
So thinking about kind of your clinical roles and coming into this, I can see how it's a natural transition for you, Beth, because you're already working in that kind of antenatal diabetes space already. But for you, Nicola, what was it that spiked your interest in getting involved in kind of the diabetes project?
So although I work in antenatal clinic, I'm not a diabetes specialist midwife by background. I've always been very involved in our diabetes clinic at work. And again, we have had a patient with monogenic diabetes. Obviously that was very interesting. And I've got a family member with monogenic diabetes. So sort of that kind of aspect initially piqued my interest.
Yeah, fantastic. And so kind of thinking back to your younger selves, in childhood, was this the kind of role that you aspired to do, kind of specialist work in genetics or genomics?
No, I'm quite old. That wouldn't have been a thing back in the day. Wouldn't have known anything about that. And
Yeah.
I honestly don't think I'd have known what a midwife was when I was younger.
Really?
Because you've got to remember, back in the day, the only representation of midwifery on TV was Nurse Gladys Emanuel.
Yeah.
So it wasn't like today when you've got one born every minute. I'm honestly not sure I'd have known what a midwife was.
Really?
Yeah.
So where did you get into midwifery then?
From nursing.
Okay.
Yeah.
So you were a nurse first.
Yeah.
And what area did you specialise in nursing?
Gynecology.
Okay. And then it was a natural transition.
Natural transition. Yeah.
So how long have you been working in midwifery now then?
Oh, a really long time.
Yeah.
What year are we? 2024? Yeah, it'd be 24 years nearly.
Yeah. Fantastic. Fantastic. And how about you, Beth?
So I am a direct entrance midwife. So I went in at 18, very bright-eyed and bushy-tailed, went off and did my midwifery training. I think my parents always thought I would do something in healthcare and the caring profession. My mum sent me off on lots of different work experience, and I spent some time with my godmother doing some renal nursing in Wales, which was super interesting. And I always thought if I hadn't become a midwife, I probably would have been a nurse and worked in renal because of the continuity you have with those patients. Although it was very challenging, I met some very people with lots of character. You'd have some of the patients who were on very tight fluid restrictions, and I heard the nurses saying to them, "Oh, I saw that you had soup for lunch." And I remember this one gentleman going, "Nope, definitely didn't." And she was like, "I can see you've got a soup bowl there." And he just adamant, and he was like, "Well, unless you've written it down, doesn't count, does it?" And he was on a really tight fluid restriction because he was awaiting a kidney transplant. But yeah, I think had I not gone into midwifery, I probably would have gone down the sort of renal nursing route after my godmother. But when I went into midwifery, I was a community midwife for years, and I always thought diabetes is it's affecting so many more women in pregnancy. And I felt quite ill-equipped as a community midwife to actually help the women when the women would come and say, "Oh, my blood sugars are high." I didn't really know how to help them. And I thought, actually, this is something that is really interesting. I want to be able to give them really good care. So that sort of sparked me to go off and do my prescribing, which then led to going into diabetes as a diabetes specialist midwife, which then led to getting this job, which has then just opened up a world of possibilities and opportunities for us.
Yeah. So in those journeys then, can you pinpoint exactly when you heard of genetics or genomics, particularly you, Nicola, who, like you say, kind of it wouldn't have existed back when you were thinking of careers?
I think probably through like the personal experience of a family member. That would have been the first experience, really. Apart from obviously in terms of midwifery, looking after women who are having Down syndrome screening and, having, fetal medicine input in terms of congenital abnormalities, anomalies picked up at scan. But probably with that.
So thinking about your kind of specialist areas of midwifery, how do you think they've maybe changed in the time that you've worked within that field? So particularly maybe you, Beth, entering midwifery and realising that care for women with diabetes, it wasn't what it should be. How has it changed, do you think, over that period of time?
Statistically, naturally, they're saying that our rates are fairly stable, but I think on the ground we feel like so many of the women have developed gestational diabetes, and I think because we are offering screening for it and we're testing more people, we're obviously picking it up more, which to me can only be a good thing, because then we're able to make changes so that the risks associated with diabetes in pregnancy can be reduced. Unfortunately, we can't eliminate the risks altogether. So diabetes can be quite a challenging area to work in, because there are situations where it doesn't matter what you do. A woman may not take home her baby at the end of it, which is devastating. But part of it, you think if you've done everything that you can, it still doesn't make it any better. But I think moving forward, as we can improve diabetes care, that will help people, and the more people that we're testing, we are picking it up more. It'll be interesting. They're currently doing a national audit of gestational diabetes. I'll be really interesting to see what they say the national rate is, because I think a lot of websites will say sort of 5 to 10% of
obstetricians say 4 to 5 in
100 pregnancies, which just doesn't seem accurate when you're
on the ground
and you're seeing women in community clinics, and it feels like every second person's got gestational diabetes. So it'll be really interesting to see what that audit does actually show.
Hi, my name's Naima Kalachand, and I'm the host of Behind the Genes, Genomics England's podcast. Join us for the latest in cutting-edge research and real-life stories from people affected by rare conditions and cancer. Through thoughtful conversations, we'll take you behind the science. Plus, check out our Genomics 101 explainer episodes, where we break down complex genetic terms in under 10 minutes. Subscribe to Behind the Genes on your favourite podcast app today.
So just for the listeners, can you explain what gestational diabetes does in a pregnancy? Why is it so important to pick up?
So gestational diabetes is diabetes that's first identified in pregnancy, and we're having a rise of women coming into pregnancy with actually undiagnosed type 2. So unfortunately in pregnancy we can't diagnose them as type 2 diabetic. We have to say gestational diabetes but likely undiagnosed type 2. So they, within my own trust, will go into a different care pathway than just somebody who's got routine gestational diabetes. But if diabetes isn't properly controlled in pregnancy, it can lead to lots of complications for both the pregnant person and her baby. The main one being that the fetus can grow very large because insulin is a growth hormone. If there's a high blood sugar, women will produce more insulin, and then that insulin will then cause the baby to then grow bigger, and that can then cause problems with birth, and babies becoming stuck and having a shoulder dystocia, women then having postpartum hemorrhages. Women with uncontrolled diabetes are also more likely to develop a condition called preeclampsia, high blood pressure, lots of different complications that can all arise from poor control. So it really is imperative that we can get the blood sugars as well controlled as possible. Unfortunately, it also increases the risk of stillbirth when it's poorly managed diabetes in pregnancy.
So clearly very important that it's picked up and managed properly. Yeah, thanks for explaining that. So can I ask you both, is there a particular case that you can think of from within your clinical work where maybe genetics or genomics played a big part that has maybe stayed with you?
Yeah, a patient I always remember came to us in her second pregnancy. In her first pregnancy, she was diagnosed with gestational diabetes. Between the first and the second pregnancy, she was diagnosed as type 2 diabetes. And then she entered the second pregnancy as a type 2 diabetic, established diabetes. Happily, one of my very lovely diabetic specialist nurse colleagues had just been on the 2-day monogenic diabetes training at Exeter University. So had this all very fresh in her mind and was, was suspicious of this patient's history, did the investigations, and she did turn out to have glucokinase hyperglycemia, which is the form of monogenic diabetes that our project is working on. Yeah.
And so what difference did knowing that diagnosis make to that patient?
Well, I think it took away a lot of the stigma that comes with diabetes, because type 2 is obviously very much seen as a lifestyle cause of diabetes, and people really struggle with that, particularly if they don't feel that they are, have got those lifestyle issues, and they feel they're being quite healthy, and they're trying to be really compliant with appointments and blood glucose testing and treatments, and it's not making any difference. It's very damaging to their, self-esteem and their trust and their belief in the medical team, etc. And it, harm their pregnancy. They feel that they're doing their baby harm, and also for her family, because she said, "Oh, my mom's type 2, her brother's type 2, my younger brother, he's really skinny, he's type 2. And all these list of family members, and of course it made a difference for them as well.
Yeah, because subsequently were they then seen and shown to be MODY as well?
What I don't know, because the pregnancy ends and you never know. The story ends there.
Yeah. But I guess it had the potential for that family.
Absolutely.
Just, as we said earlier, the importance of distinguishing so that you're not over treating. And for you, Beth, is there a case that sticks with you?
I think when you hear back of patients that you have been correctly diagnosed, our line manager had some of her colleagues come to a study day that we put on in February, and they very excitedly came running down the corridor and saw her and said, "Oh, we must tell you that we've diagnosed a patient with glucokinase hyperglycemia," and all thanks to the study day.
Wow.
Because they hadn't heard of it at all beforehand. And it's cases like that you just think, actually, these are small numbers that we're talking about, but for these women who we can correctly diagnose, it's so important. And I keep thinking back that they're already out there. They're in the gestational diabetes pathway, but we just haven't identified them yet because the maternity diabetes teams don't know about it. And the more we can educate and share this information, the better. Like we're saying about with patients' family members then going on to being correctly diagnosed. I think that just gives me a real sort of buzz that we can help.
That's a huge win. Yeah, absolutely. So I was going to go on to ask you about what a good day looks like for you. And so I imagine it's that, is it?
Yeah, I think when you have got patients that are suitable for testing and you can send that blood off, it's really exciting that you might then get the correct diagnosis. I have had patients that you don't then get a genetic diagnosis, and that can be quite surprising because you think actually this person really does meet the criteria, but as our colleagues down next to would say, they would say, well, we don't know all the genes as yet. And I had one patient who a genetic cause wasn't found for her diabetes, and I said to the team, I'm really surprised about that. And they said, well, her blood can be re-looked at in a few years if we identify more, because it wouldn't surprise me if we just don't know about it just yet, because she just didn't fit the criteria of having type 2 classically. So I always think, will we find out in 10-15 years that actually there was a genetic cause that we just didn't know about at the moment.
Yeah. And for you, Nicola, what's a good day look like?
What a good day is if one of my colleagues has some suspicions from something I've mentioned to them about this, that a patient may have a genetic cause of diabetes.
Yeah. And what I'm hearing, it's that kind of, the positive result of the work that you're doing on the project's really being seen on the front line and, kind of making a difference to patients.
It's so lovely to see colleagues who this hasn't been on their radar previously, and when you start talking about it, you can see all the cogs whirring as they think back to a patient they've looked after in the past, and they always knew in the back of their mind was atypical, didn't quite fit the normal presentation, and start questioning whether that patient's existing diagnosis is the correct one.
On the flip side of that then, what's a challenging day look like?
We've probably had quite a few recently. We decided that as beneficial as face-to-face study days are, you can't always get everyone there because of clinical commitments.
Of course,
maternity diabetes teams, I would say, are particularly stretched at the moment, and trying to free clinicians up to actually go to study days can be quite challenging. So we thought we'd take it on ourselves to make a e-learning module. And we were told, it'll be 8 to 10 months wait to get a company to do it. So in our naive wisdom, we thought, well, we'll just make it ourselves. So along with a very lovely colleague called Nicola Hussein, we have created an e-learning package. And it has been hugely challenging, and we wouldn't have completed it without Nicola Hussein's technical know-how. I like to think I'm quite tech savvy, and I couldn't even change the background colour on the programme we were trying to use. And we now are just about to launch the e-learning module, and it's very nearly finished. We're just waiting for the last sign off from one of our endocrinology consultants, which is super exciting because that will be a lasting resource that will be free for clinicians to access, and hopefully won't need too much updating.
And is that available just locally, or will it be a national?
It's national.
Oh,
so we've
incredible.
done it so that it'll be hosted on the NHS Learning Hub, which most colleagues will know as e-learning for health is all being moved over to the NHS Learning Hub. So clinicians can go on and access it, and they can get a certificate of completion. Initially it was going to be like a 20-minute little module.
Yeah.
We think it's about a 60-minute module now. But it's been hugely challenging, and we've learned a huge amount doing it. And anytime we've then thought about having patient feedback about aspects of our project, we've been able to incorporate that into the training. We then asked quite a few colleagues to do the sort of template training and feedback. So it's been ever evolving. We like to say we're probably on version 17 of the of the e-learning.
Yeah. Well, like you say, although it's been challenging, what an incredible achievement to result in a national education resource that's going to hopefully, be impactful for so many midwives across the UK. That's amazing. And so you mentioned there's different aspects to the work you've done. You've mentioned the e-learning. What else have you got going on with your projects?
Well, we've already created other resources to support clinicians. So because our thought process was always, as a clinician, if I'm in the position of talking to a patient about this, what would I want? What would I need to support me? So the first thing we created was the patient information leaflets, because there weren't really any out there. The e-learning module to support staff. And then we've also created some sort of small resources, again, to act as prompts for staff that are available on the same digital platform. We've run one study day back in February that was well attended. It was really well received, so we were really happy with that. And we're just about to host another study day in a couple of weeks in the East region.
Fantastic. So the first one that you did in February, was that in a specific area, or again, was it a national audience?
It was originally, it started out as Southeast, and then it kind of grew because there was a lot of interest, because this was originally a national transformation project. And there was a lot of interest from other regions. So then they said, well, we'd like to pay for some places. And it really grew, didn't it? We had nearly 100 people attend. And it was went down way better than we could have ever imagined.
Yeah, that's great. And so good luck for the next one.
Thank you.
So looking then to the future, what have you got planned, or where would you like to take this work next?
It would be lovely if we could get some more funding to carry it on. So in my wisdom, we just thought, let's go and write one. So we did. And as the NHS doesn't have a standard sort of template, and each trust will have their own sort of local thing that they need to be in their SOPs, we decided, well, we'll do a generic one that people can then use.
Yeah. And I hear the passion in you to, continue this and take it further. And you can see why when, you're literally, in your clinic seeing the difference that your work is making, not just to, the patients, as we've talked about, the benefits of getting a correct diagnosis, but also to the staff feeling empowered to make those conversations happen. So well done to both of you. I can hear what the rewards are of the projects in terms of the benefits to patients and staff that you're seeing. But on the flip side, in terms of the kind of major challenges of this project, what have those been?
I think a lot of the maternity diabetes teams are incredibly stretched, and we have an initiative within maternity called Saving Babies' Lives, Care Bundle version 3, and element 6 of that is all to do with diabetes. But monogenic diabetes doesn't feature in that. And it's very challenging when there are these huge aspects that need addressing, to then go to teams and say, well, actually, a small percentage of your cohort may be incorrectly diagnosed. We'd like to change that. It is a very sort of difficult sphere to break into. But as we said before, these patients, they're already in the cohort. It's just finding them that's the important thing. So it's not that we're changing anyone's genetics by correctly diagnosing them. They've already got this genetic change, and actually their long-term health could be really impacted by making this correct diagnosis. And it is small numbers we're talking about. We're looking at testing maybe under sort of 5% of the gestational diabetes cohort, because there's very set criteria of who can be tested. But yeah, for those individual patients, we're looking at possibly 300 patients across England a year could have this and could come through the gestational diabetes pathway. So for those 300 patients, actually, we could make all the difference for their future health and their child's health and their family's health. And I just think about the costs to the NHS of unnecessary medication and unnecessary foot checks and unnecessary retinal screening, when actually they don't need any of it.
One of the challenging aspects of the work with monogenic diabetes is there's no NICE guidance relating to this. So there are no national guidelines. The only clinical guidance is the guidance provided by the team at Exeter University and Royal Devon University Hospital, who are the global centre of excellence for monogenic diabetes. We're lucky enough to have that in this country and their expertise, and they've been very involved with all of our work and very supportive of the project, which is amazing. But there is no NICE guidance, and without NICE guidance, you don't get KPIs. And without KPIs, it's very difficult to ask clinicians to tackle yet another thing when they have so many pressures and challenges at the moment.
If you could use this podcast to kind of reach out to those clinical staff that are on the ground, what would you say to them?
I'd say to them, if there's a patient that you keep reflecting on because their presentation isn't typical and it just keeps coming back into your mind, you might be right. It might not be gestational diabetes after all. And I would say, check out our e-learning module, which is available on the NHS Learning Hub for free to all staff with an NHS email or a .ac email account.
Fantastic.
I think, as Nicola said, it's those patients that don't quite fit the mould, and particularly within the diabetes teams, they may have slim women who have entered the gestational diabetes pathway and just think, how's this woman ended up with gestational diabetes, and then she's needing insulin, but it's not really affecting her blood sugars, and you're having to increase her insulin sort of a couple of times each week. That would really give a sort of clue of actually, is this normal gestational diabetes that's just been caused by the pregnancy hormones making us more insulin resistant, or actually has this got a genetic component? Because if we do get that correct diagnosis and then can offer fetal testing. So in the last few years, fetal testing for glucokinase hyperglycemia has become available. So when you have a woman with known glucokinase hyperglycemia from 12 weeks of pregnancy, we can offer fetal testing. So we've had fetal testing from maternal blood samples called non-invasive prenatal diagnosis for a couple of years for different things. So one thing we use it for is when a lady has rhesus negative blood, we can take a tube of blood from the patient and then it can isolate the fetal DNA, and then we can tell whether or not the baby has positive or negative blood, and whether or not the lady then needs anti-D in the pregnancy. So that's where it's been used quite widely, but we can use the same technology for monogenic diabetes for any form that can affect the fetal growth. So there's two subtypes that you would use non-invasive prenatal diagnosis for, and glucokinase hyperglycemia is one. So when you have a woman with glucokinase hyperglycemia and her baby has inherited the same gene change, those families, that lady needs no treatment in pregnancy, and we can actually discharge them from the maternity diabetes clinic. So these would be people who classically would be on high doses of insulin, offered an early induction of labour. But if the baby has also inherited the gene change, there's no risk of having a larger baby, and they can be discharged back to...
So again, a really massive impact directly on patient care, isn't it?
Yeah. And the fact that it can be done from 12 weeks. So if we can correctly diagnose people in their first pregnancy, as midwives know, these women come back to us some year on year on year. And And actually, if we can correctly identify them in that first pregnancy, and then at 12 weeks, they can be offered the NIPD, it can just make all that difference to their pregnancy. If some may not even enter the needing to monitor their blood sugars, if we can get that result back within a few weeks, actually, if that fetus is then shown to have inherited the same gene change, we can know that mum and baby are safe, and we don't need to do anything with them.
Fantastic. Well, thank you so much, Beth and Nicola, for joining me today. It's been really interesting to hear about the project.
Thank you for having us.
Thank you.
Thanks for listening. If you would like more information about the topics that we have discussed today, then you can find these on both websites, ney-genomics.org.uk/podcast and southeastgenomics.nhs.uk/GMSA. You'll also find here all the episodes in our podcast series. All episodes can also be accessed via Spotify, Apple Podcasts, and all other major podcast platforms. Thanks for listening.